Dear participants, my name is Gab McDonough, and I'm the Educational Action Supporting Officer at ERN-EuroBloodNet, the European Reference Network for Rare Hematological Diseases, and it is my great pleasure to welcome you to the ERN-EuroBloodNet Thursday Webinars. The aim of these educational activities is promoting the interest on very innovative topics in order to stress among health professionals the cutting-edge advances in the field of rare hematological diseases. Webinars are mainly addressed on very rare diseases, complex disorders, highly specialized procedures, and the implementation of guidelines. At the same time, webinar programs that are specifically addressed to patients intend to increase awareness on a specific rare hematological disease among patient advocates and patient associations. Before we start, let me share some home rules. Please note that the session is recorded and will be uploaded to the EBN e-learning environment on our YouTube channel. If you do not wish to appear, please turn your camera off and change your name on the platform. Also, please be kindly informed that your microphone is muted. If you have any question about the presentation, please write them in the chat. They will be addressed during the Q&A session at the end of the webinar. So today's webinar is on the management of relapsed refractory acute lymphoblastic leukemia in adults by Professor Nicolas Boissel. Professor Nicolas Boissel is the head of the Adolescent and Young Adults Unit of the Department of Hematology at Saint-Louis Hôpital and is a professor of medicine at the Université de Paris, Cité, France. He is engaged in therapeutics for patients with bone marrow disorders, including acute leukemia, lymphoma, and bone marrow failure, with a specific focus on adolescent and young adult comprehensive care. He is also the chairman of the French, Swiss, and Belgian Group for Research on Adult Acute Lymphoblastic Leukemia, GRAALL, and Professor Boisel's clinical research interests include notably the role of new oncogenic events and minimal residual disease to stratify therapeutic approaches in acute leukemia and the development of immunotherapy in the field. And with that introduction, the floor is all yours, Professor. Thank you very much for joining. It's a pleasure to have you, and the floor is all yours.
Thank you, Gavin, for the nice introduction. And if everything is okay, can hear me and see the slides? Yes. Okay, thank you. So I'm so very happy to spend this hour on this important subject, which is the management of relapsed refractory acute lymphoblastic leukemia in adults. And obviously, I will focus this presentation on the treatment of B-cell acute lymphoblastic leukemia. But of course, we will have time to discuss the treatment of other conditions. Here are my conflicts of interest. And as you probably know, before the era of immunotherapy, we made some progresses frontline in the treatment of adult acute lymphoblastic leukemia, mostly by implementing pediatric-inspired, more intensive approaches in young adults with some toxicity in patients older than 45, 60 years old, mostly in using asparaginase. And also by implementing about 20 years ago tyrosine kinase inhibitor for Ph-positive B-ALL. But about 30% to 50% in some trials, patients still relapse with very, very poor outcome. So these are the French experience about the outcome of patients, again, before the era of immunotherapy in the 90s and in the early 2000s, in our LALA 94 and GRAD 2003 and 2004 5 trials. And as you see, the median overall survival did not improve, about 6 to 7 months, and only few patients are long-term survivors. About 10 to 20% of them are finally cured after relapse. And many groups, including our, have described the prognostic factors at relapse. And as you know, it's not about ALL biology at relapse, maybe about MRD, but we have few data, large data set of the use of MRD at relapse. It's more about first complete remission duration, and the longer the duration is, the higher you have the chance are to cure the patients. It's about also the chance to reach a second complete remission in these patients, and also to bridge them to allogeneic stem cell transplant. And for a long time, there was absolutely no standard of care when compared to children, to pediatricians that have used for a long time very standardized chemotherapy and stratification of risk. No standard care was available in adults. And you see here the results or the outcome of patients in two European cooperative groups, in France on the left and in Germany on the right. What is important here is that a second complete remission can be reached only in about 40 to 50% of patients. But if the CR1 duration is long, higher than 18 months in our experience, or in the German experience, and if you used standard induction, you may increase this complete remission rate to 80 to 90% with a small percentage of patients. But that's, I think, the first message for today is that chemotherapy at relapse is not over. And for patients that experience a very late relapse, then to reuse a standard chemotherapy, of course, and we will discuss how to consolidate them, can be a good option. So what do we have in terms of new drugs approved for relapse refractory BLL? You know, that is mostly about immunotherapy. And we have an ADC, antibody drug conjugate, that's inotuzumab ozogamicin, that targets CD22. And the payload is cheliquamycin, that is, so the antibody is internalized and create double-strand lesions and the death of the cell. So in the iNOVATE phase 3 study, the inotuzumab ozogamicin was superior to standard of care. And again, there was a mix of chemotherapy compared to inotuzumab as single agent. And the overall response rate was 81% versus 29% after chemotherapy, with 80% of patients that reach a complete MRD response. As you probably know, there is a specific safety profile of this drug, since it's more about chemotherapy linked to an antibody, but chemotherapy. And the two most frequent toxicities are first cytopenia, but also liver toxicity, including veno-occlusive disease that mostly occur if you want to bridge the patient to allogeneic stem cell transplant. The second drug is a first-in-class, is a bispecific antibody that recognizes CD19 and CD3, named blinatumomab, that was again compared in a phase 3 study, the TOWER study, to standard of care, meaning different kind of chemotherapy. The overall response rate was lower, 44%, but significantly higher again than chemotherapy, 25% in this relapse refractory setting. And again, the MRD response among the responders, patient in CR, was about 80%. The most important toxicity of this drug, I didn't mention cytokine release syndrome because it may happen, but it's less frequent than with CAR T cells, is neurotoxicity that may occur in about 10 to 15% of patients. Also, if the drug, and I will come back to this point, is used in a minimal residual disease setting. And I will come back later. 2 CAR T cells were approved in Europe, one for children up to 25 years old, and the other one for a patient older than 25 years old, Tisacel and Brexucel. So the label of Brexucel is a little bit different than in the US, and we are allowed to use it only for patients older than 25 years old. So, of course, they were evaluated in 2 different kinds of population, children and adolescents and young adults for Tisacel and adult for Brexucel. And both of them yielded about 70 to 80% overall response rate, with good MRD response assessed by flow cytometry. And I will also come back to this point. And as you know, the most frequent toxicity observed after the use of CAR-T is cytokine release syndrome and ICANS. I will focus the first part of this presentation on first relapse. And so it will exclude CAR-T cell, and I will mention CAR-T cell later on this presentation. As you know, the access of CAR-T cell is maybe limited in some patients, and in many countries, only for patients experiencing a second relapse or in first relapse after allogeneic stem cell transplant. So if you come back to the two phase 3 studies, the first one was blinatumomab, the TOWER study, included more than 100 patients in first salvage compared to standard of care. So half of the patient, because there was a 2-to-1 randomization in the TOWER study. If you use in salvage 1 blinatumomab, you may expect to have a higher rate of complete remission rate, including CRH and CRI, more than 50% versus 36.5% for patients with a standard of care. And as you see here, the overall survival, the best overall survival that you can observe is with blinatumomab given to patients as first salvage, with 11 months overall median overall survival. With inotuzumab, the same kind of subgroup analysis was performed after the publication of the INNOVATE study, where 100 patients, more than 100 patients in salvage 1 were compared to patients receiving standard of care. And here the complete remission rate, including complete recovery, was almost 80%, with again 80% of patients that reach a complete MRD response. And the median overall survival was quite short, about 8.6 months, but with again an improvement also with the rate of long-term survivors, 26% here at 2 years for first salvage, receiving inotuzumab as first as a single agent. So of course, the benefit of both of drugs was greater in first salvage, and it's difficult to compare these two drugs, and there was no back-to-back comparison or randomization, and in these two studies, eligibility criteria were quite different. The second study that was important is that started before the TOWER study, was to assess the response to blinatumomab in the MRD positive situation. So in patient in complete remission with a poor MRD response or with MRD relapse. And the majority of these patients were in first relapse, in second remission, first relapse and second remission with MRD, were in first remission with MRD positive, about 2/3 of them. And so there is no comparative arm, but what we have observed in this study is that the patient that responded to blinatumomab had quite an impressive overall survival of about 50% at 5 years in the updated outcome. And interestingly, there was some similar results observed for CR1 patient or CR2 or plus patient that could also indicate that blinatumomab in consolidation in second line could also yield some interesting results. Two important studies were performed in second complete remission in the children and AYA population, one by the Children Oncology Group on the left, and one in Europe by a consortium. It was an Amgen study on the right. And both of them compared blinatumomab as consolidation versus standard chemotherapy in high-risk and intermediate-risk patients, mostly in bridge to allogeneic stem cell transplant. And in both of these studies, the blinatumomab arm was superior to the chemotherapy arm, with quite nice results in terms of overall survival. Of course, it's a children population, but at high risk or intermediate risk at relapse. And but it was, I think, two important studies to demonstrate the efficacy of blinatumomab in the situation of complete remission. And in adults, so far, we have very poor or limited data about the use of blinatumomab in second complete remission. And in France, we try to collect this data as a real-world experience. And a first publication in 2022, we collect all the data for the early access in France in relapsed refractory setting or in complete remission. And you can see here that in relapsed refractory setting as a single drug, the outcome of patient was quite similar of what was observed in the Tower study. But for a patient in relapse, and that was patient in second CR or in later complete remission, those who received blinatumomab had quite a good outcome, similar to what was observed in pediatric groups. And later on, we did a second publication with a cohort of patients that was collected in our center in Saint-Louis Hospital, where we have used consecutively blinatumomab for relapsed refractory and then mostly for patient debulked. So in first complete remission or in second complete remission. And again, it was interesting to see here that in blue, the patient that received blinatumomab as single agent has, in fact, the same kind of outcome than in the Tower study. So with about 6 to 7 years median overall survival. But the patient in CR1 or in CR2 that received blinatumomab had a quite impressive outcome, particularly for a patient in CR2 with no difference with the two populations. In CR2, about half of the patients, 55%, were bridged to allogeneic stem cell transplant. It gave the idea to some of our centers to develop a strategy where chemotherapy, a debulking chemotherapy, was combined to blinatumomab. And again, here, that's the experience of the center of Bordeaux in the south of France, where a chemotherapy that was imported or inspired from a pediatrician named Vanda, with a combination of dexamethasone, high-dose RAC, P16, mitoxantrone, and asparaginase, was combined with blinatumomab. So it's a block of salvage chemotherapy, followed just at the end of the block with blinatumomab, started at day 7, just a day after pegylated asparaginase. And in this population of patients, the rate of complete remission was quite interesting, about 82%. And with 64% of patients in a complete MRD response, about 2/3 of these patients were bridged to allogeneic stem cell transplant. And the 1-year overall survival was 65%. But it's a quite small group, small study, showing that blinatumomab could be combined to a debulking, quite intensive debulking strategy, and could so bring the patient in a long-term remission and long-term or 1-year remission. But as you know, when the patient relapse, most of the relapse occur in the first to 18 months. After second relapse occur in the 12 to 18 months. So about blinatumomab, what do we know about the determinants of response? The most important message here is that tumor burden is the most important limitation or high tumor burden to the efficacy of blinatumomab. And I think that most of you have already incorporated this message. And what is interesting is that it's true at relapse. So if you use in overt relapse, you may expect a limited effect of blinatumomab. It's true also for extramedullary disease. And as illustrated on the right, is also true in first complete remission when you have patients with high MRD levels. So if you have at the MRD level, if your MRD is quite high, you may expect higher risk of relapse. It has been nicely shown by the Italian group. There is no clear genomic profile associated with the risk of resistance to blinatumomab, but I think we should investigate this further. For sure, and I will mention this later again, there is an increased risk of CD19 relapse in some subgroups, mostly immature B-ALL with KMT2A rearrangement, with ZNF384 rearrangement, or in low hypodiploidy or in patients with the loss of chromosome 16, since CD19 gene is encoded on this chromosome. So it's easier to lose one gene versus two genes to escape with the loss of the antigen. The third important prognostic factor for blinatumomab is the MRD after blinatumomab. And on the lower panel here, the French group, again, frontline, compared the prognostic impact of MRD response to chemotherapy at the same time in a protocol to chemotherapy versus blinatumomab. And as you see, the hazard ratio is exactly the same. So meaning that the higher risk to relapse when you are MRD positive after chemotherapy or blinatumomab is exactly the same. So the most important prognostic factors are summarized here is MRD before blinatumomab and MRD after blinatumomab. Of course, as you know, one of the escape mechanisms that was clearly described is the loss of CD19 antigen. It was also described for CD19 autologous CAR T with different kind of mechanism. And there are a lot of different description biomarkers coming from the analysis of the tumor immune microenvironment, the high percentage of Tregs, the high percentage of T cell exhaustion that correlates with higher risk to be resistant to blinatumomab. But to my knowledge, none of these were validated prospectively. So about blinatumomab, one of the last points I would like to mention is, as you probably know, a sub-Q formulation is being developed, and that we had the first publication last year about the first results of the phase 1 in about 30 patients with 2 different dose levels. Of course, it's easier to give with a sub-Q formulation, but also it allows to have a different pharmacokinetics with a high concentration of blinatumomab at the peak just after infusion that are quite different than what is observed with a continuous IV infusion. And in this context, the first results reported at these 2 dose levels were quite exciting. Remember, about 40–45% of complete remission with IV, and here is about 80–85%, even 90% with a 500 microgram. And well, it has been also reported that probably the price to pay is an increase also risk of CRS and neurologic event, about 20% of grade 3 and plus CRS, and 25–40% of neurologic event that remind us about more the toxicity about CAR T cell. So probably the development of this drug will probably come with a mitigation plan of the risk of CRS and ICANS. Back to inotuzumab, we have very few experience with inotuzumab in a relapsed refractory setting outside the prospective studies. But that is an important study from the MD Anderson that was also published last year, where population of patients with MRD positive ALL were exposed to inotuzumab and 2 cycles. The first cycle with fractionate at day 1 and day 8 at 0.6 and 0.3, and cycle 2 to 6, 0.3 at day 1 and day 8. And as it was reported with blinatumomab, about 80% of MRD conversion is with inotuzumab. It's about 70%. So inotuzumab is also maybe used in patients where you have persistent MRD to bridge the patient to an MRD negative status and maybe a better condition to bridge to transplant, even if we have limited data about MRD positivity at relapse and success of allogeneic stem cell transplant. Here, of course, in the population of patients recruited in this study, you have 2/3 of CR1 patient and 1/3 of patient in CR2 or later CR. Of course, none of these agents are used as a single agent. And I think that one of the important message also is that the combination of low-dose chemotherapy plus inotuzumab and also blinatumomab in consolidation are probably a way to improve the outcome of BLL with pH negative BLL at relapse. And it is here illustrated by this study by the MD Anderson that combined mini-HCVD plus inotuzumab and blinatumomab in consolidation in patients with a median age of 37 years old. And 90% of this patient had prior allogeneic stem cell transplant. And again, the 2/3 of them were in salvage 1. And the outcome of patients in salvage 1 are shown here on the red curve versus later complete remission on the in first relapse are on the red curve, and other patients in the blue curve. And what you can see here is that this kind of combination led to a 3-year overall survival of 49%. That is and a plateau at about 40%. That is much higher than what was observed with chemotherapy alone. And on the right, since blinatumomab was implemented during the protocol, you can expect even a better survival of 60% in patients that receive blinatumomab in consolidation. So it's quite similar at what we have observed in our own real-world experience. What about the determinants of response and escape for inotuzumab? There is clearly a limited impact of tumor burden, as it is the case with chemotherapy. I will show you, as for blinatumomab, results from the frontline use. Here on the right, the curves are from the EWAL-INO study, combining inotuzumab plus low-dose chemotherapy in a frontline setting for elderly patients. What is interesting also is that the CD22 expression, level of expression is important, with the same kind of cutoff that was used for Mylotarg, for gemtuzumab. It's about 70%. And also the genomic profile is sorry for the slide. And the genomic profile here on the right is associated with a higher risk of resistance to inotuzumab. MRD response is also of importance, as high MRD levels is associated with an increased risk of relapse. And there are many other mechanisms that were implicated in the relapse itself. Things scalicamycin induces the DNA double-strand breaks. Many acquired mutations were observed, including TB53 mutations, and also hypermutation syndromes, including mutation of CD22 that led to the loss of CD22 expression. And also increased drug efflux may lower the efficacy of the calicheamycin payload. So in the last part of this presentation, I will mention the approved autologous CD19 CAR T cells. I mentioned Tizacel and Brexucel earlier in this presentation. And as you probably know, there is also a third CAR T approved in the US for relapsed refractory B-ALL that may be approved in the next months by the European, the EMA. And this CAR T was constructed with the specificity to have a fast off-rate anti-CD19, meaning that there is a modulation of the recognition of the CD19 antigen that control the activation of the CAR T. And the aim was to reduce the toxicity of the CAR T. And interestingly, if you go on the lower part of this table at CRS and ICANS, you can see that yes, the rate of grade 3 and more CRS and ICANS is lower than what was reported with Tizacel and Brexucel. So first of all, we have only a limited phase 2 to explore the efficacy of these CAR Ts. About 80% of the patients were finally infused because of progression, sometimes because of the defect of production, so the manufacturing failed, but in a very limited number of patients. The overall response rate is about 75 to 80% of patients. When you use flow cytometry again, almost all patients reach a complete MRD response. But if you use more sensitive PCR, then like NGS, you increase your rate of MRD positivity at the 28 up to 15% here, and more in a real-world experience with other CAR T cells. And we have now some publication about the long-term outcome of these studies. In the ELIANA study with Tizacel, the overall survival is not reached so far. And in the Brexucel and Obe-cel study, the median overall survival is about 25 months for Brexucel, and it's about 15 months in the FELIX study for Obe-cel. So meaning that, of course, it's a non-comparative study, but the median survival that were observed here are higher. That was reported in the phase 3 with inotuzumab and blinatumomab, but of course in different population of patients. So what about the prediction of the efficacy of the CAR T? First of all, like for blinatumomab, the high tumor burden was observed as a major prognostic factor in almost all CAR T cell in academic studies, but also in registry studies. Here on the left is an impact of high tumor burden in a cohort of mostly Tizacel, but also CD19 CAR T cell. And as you know, it's not only about the higher risk to fail or to relapse, but the high tumor burden is also associated with a higher risk of CRS, of ICANS, of infection, of cytopenia, and also with the risk of CD19 negative relapse. There are so far very limited data on the impact of debulking. And in our experience, debulking may improve the safety, but it's not sure that if the disease is really resistant to debulking, it improves the outcome after CAR T. But again, it was not clearly published so far. And in the Felix study with Boissel, you can see here on the right the effect again of a low, less than 5% versus high in red, more than 75% of blast at the time of lymphodepletion. The second important prognostic factor for CAR-T is, as I said, the MRD response, with the condition that you use a very sensitive MRD method. The flow cytometry that we use for ZUMA-3 and for ELIANA study showed that almost all patients were MRD negative. But in fact, if you use NGS or if you use qPCR, like it is a case in most of the countries in Europe, then you may be able to detect patients that will be exposed to a very rapid evolution of the disease. And also what is important is when a patient is MRD positive just after CAR-T, so 1 month after CAR-T, the risk of CD19 negative relapse is increased. The second one is the exposure to blinatumomab, and there are some conflicting data about the impact of blinatumomab, but it's an important field because, as you know, blinatumomab will be used very frequently now in frontline following the E1910 study of the ECOG group. And again, in the US cohort with a Tisa-cel and other CD19 CAR-T cell, the outcome of patients that failed prior exposure to blinatumomab, so mostly in relapse refractory setting in this study, have a very dismal outcome after CAR-T. Those who did not fail are a similar outcome. And on the right, you have the experience in the ZUMA-3 study, where the patients that were exposed to blinatumomab have a lower expansion of the CAR-T and also tends to have a lower complete remission rate and worst survival. And probably the difference in terms of outcome comes from the lower complete remission rate, 60% versus 80%, and not from the risk of relapse, but this cohort is very small. End of prognostic factors that is important when you monitor your patient with CAR-T is about the CAR-T persistence. And you know that normal B-cell aplasia is a surrogate marker of this persistence, but it's also difficult to assess the role of this persistence because it's a time-dependent event that can occur at 3, 6, 12 months. So in many studies, loss of B-cell aplasia were associated with an increased risk of CD19 positive relapse. And whatever the time from infusion to the loss of the CAR-T. And just as a history, we had recently a patient that was in remission with a loss of with a B-cell aplasia for more than 6 years, and then suddenly he recovered from B-cell aplasia after 6 years and relapsed 1 month later. So it's just about one patient, but probably in some patients, in some ALL, BLL patients, the persistence of CAR-T, like for the first patient that was infused, that you probably heard about, Emily, that is now about 13 years after infusion in 2012, that still have CAR-T persistence with IgIV repletion because of hypogammaglobulinemia. So in some patients, maybe the persistence of CAR-T is of importance to maintain the remission. And another example of the importance of CAR-T persistence is the development of allogeneic CAR-T. On the left panel, it's about CD19 CAR-T, UCART19. The study was published about 2 years ago. And more recently, CAR-T used for TLL. Both of them are allogeneic from non-related, non-compatible allogeneic donors. And in both cases, the persistence of the CAR-T is very low. And the patients that are in a persistent complete remission after this kind of CAR-T were bridged to allogeneic stem cell transplant here, for instance, on the yellow points here on this graph. So these CAR clearly in ALL are developed as a bridge to allogeneic stem cell transplant. So there are determinants of disease progression after CAR-T, which are mostly prior exposure to blinatumomab or prior failure to blinatumomab, high tumor burden, but also MRD positivity at day 28. And these markers are associated mostly with CD19 negative relapse. Whereas if you lose your CAR-T and you observe B-cell recovery, then it's mostly associated with CD19 positive relapse, which of course makes sense. So in this patient, I think that intervention, post-CAR-T intervention should be discussed. Of course, first of all, allogeneic stem cell transplant, if not previously reported. And based on this risk of CD19 negative versus CD19 positive relapse, you may discuss what the best bridge to allogeneic stem cell transplant. For instance, in patients that receive CAR-T cell with very rapid loss of CAR-T cell, if we are not able to do very rapidly the transplant, then we expose them to blinatumomab because we think that it's the best way to maintain the remission, and that the risk of the patient is not about the loss of CD19 antigen. So the important question that I mentioned earlier in this presentation is what will be the impact of the wide use of blinatumomab, as it is the case in many of your cooperative groups. First of all, what has been observed mostly in Ph positive ALL, but also in all trial where it has been tested to de-escalate chemotherapy, is about the increase of central nervous system or extramedullary relapses. Here you see the two important studies, frontline from the Anderson and from the GMEMA, with a combination of blinatumomab and tyrosine kinase inhibitors, known as chemo-free approaches, where few patients relapsed, but half of the patients had isolated CNS relapse, whereas this kind of events is quite rare when you use chemotherapy plus tyrosine kinase inhibitor here in our experience. So the second one is that probably we will see an increased rate of CD19 negative relapse and maybe other immune escape mechanism. The second one is that we will probably decrease the use of allogeneic stem cell transplant in first complete remission. So it will be a chance for our patients, if they relapse, to bridge them to allogeneic stem cell transplant if it's required, and probably to increase the survival after relapse. And the last one, and it's probably the less known, is that the use or the use of blinatumomab, for repeated courses of blinatumomab, may probably also modify the T cell repertoire, the fitness or the exhaustion of this T cell, and maybe it may have an influence of the T cell that you can harvest at relapse, and we should be aware of that, and monitor the T cell that we are harvesting for the patient in second or third line for CAR-T manufacturing. So in the conclusion, I think that so the most important factor again for a patient at relapse is CR1 duration. That for late relapse, chemotherapy remain, I think, a good option to reach a complete remission, and after to bridge the patient to a consolidation with blinatumomab, for instance. Combining chemotherapy and different kind of immunotherapies in first relapse has shown, like in the MD Anderson study, very promising outcomes. So I think that there is a chance to be cured also at relapse now. Blinatumomab should be preferred for patients with debulk disease, whereas inotuzumab may achieve high response rate, but with a specific safety profile that you should know, and I didn't come back to this point, but you should limit the use of inotuzumab if you want to bridge the patient to allogeneic stem cell transplant, and closely monitor the hepatic tests before transplant. So CAR T cells are also very promising, but what we don't know is that which consequence will have the wide use of blinatumomab frontline, and I think it remains to be explored. So thank you for your attention, and of course it's open to discussion.
Perfect. Thank you very much for your wonderful presentation, both comprehensive and full of expertise. We have one question here.
Yes, from Matteo. Hi, Matteo. So I read with interest the latest review of Emmanuel Clapier and Marie Passet about the 26 genomic subtype of BLL, and there are some prone to lineage switch, right? NF384 and KMT2A, others like the low hypodiploid, which often lose CD19 with less CD20 expression. The set of the RHD clinical practice. Do you take into account genomic subgroups when you have to choose salvage chemotherapy, or for now is something? No. So far at Relapse, there are so limited data about the biology of the ALL and what you expect from a salvage strategy. It's clear from large frontline study, like for instance in the EWAL-INNO study, that patients with that are more frequent in elderly population with KMT2A or with hypodiploidy and with TP53 mutation are more prone to relapse after inotuzumab. But I think that we have to more precisely define what kind of resistance was in action. Is it a standard resistance to chemotherapy, or is it due to a loss of the target? It's not deciphered so far. So at Relapse, we do not integrate the biology of the BLL to decide what to do. But of course, now that we are using like blinatumomab frontline, you should be of course aware that a lower CD19 expression is associated with a resistance to blinatumomab, and probably, of course, it is more frequent in some subgroup of patients. But it's more about the phenotype than the subgroup of ALL itself.
Thank you very much for your answer, and thank you, Matteo, for the question. I have a thank you from him. We have a few more minutes left. This is a wonderful opportunity to ask the professor if there's any other questions. Here we have one. Thank you very much. I'd like to ask your point of view regarding relapse after LOSCT. Are CAR T enough or second transplant is mandatory?
So yes, it's an important point, since CAR T is a good option for a patient in first relapse after allogeneic stem cell transplant. There are converging data that suggest that late relapse after allogeneic stem cell transplant have a better outcome than early relapse, probably because of the fitness of the T cells, and probably even in late relapse more than in patients that were not transplanted before. So maybe, and it's something that we have to look after, and it's not that simple. Maybe they could benefit from also like a GVL effect when the CAR T are infused. So that's my first comment, and that's not the response to the question. So in general, unfortunately, the relapse occur in the first year after allogeneic stem cell transplant, and in this setting, we try to avoid to transplant the patient. But again, what we have done in some patients with early loss of CAR T is to expose them to blinatumomab and to discuss donor lymphocyte infusion. And interestingly, there were some long-term survivors of these procedures. As you probably know, in the United Kingdom, some also experience about the use of simple maintenance phase were published with exciting result. I think there is a trial that explore the role of maintenance single in patients that lose CAR T cells early than 6 months. So just 6 MP plus methotrexate. So that's an interesting point, because when the patient was already transplanted in first complete remission, the patient was not exposed to this kind of therapy. And I think it's also an important therapy to eradicate the clone. So to come back to the question, we try to guide our decision on, of course, the time from first allogeneic stem cell transplant, but also to the MRD post-CAR T, and to the loss of B-cell aplasia. So again, if the patient loses a CAR T cell, we try to use blinatumomab, DLI, and then standard maintenance. It's more difficult when the patient has a D28 MRD positivity, because we know it's probably CD19 negative clone selection. And for this kind of patient, we have a limited option. So if you're quite late in the post-allogenic stem cell transplant history, you can consider to transplant the patient very rapidly. But as you also know, the second transplant is difficult to provide after the same kind of conditioning or regimen than in the first transplant. And so there is limited data that say that this patient benefit from a second transplant. So the allogenic intervention that we have provided to our patient is more about DLI combined with blinatumomab in patients that lose CAR T cell. And in other patients, negative MRD at day 28 and persistence of CAR T, we try not to provide a second transplant.
Great, thank you very much for your question, and thank you for the answer. We just have a few more minutes left. If anyone has any last questions, this is an excellent opportunity. I'd also just like to announce that we've put online all of the Thursday webinar videos on our YouTube channel, so those are accessible now. And if you've enjoyed this presentation, this presentation will be available soon on our YouTube channel. And this is really one of the advantages of this webinar series, is this information is easily accessible. So perhaps we'll ask one last time if there are any remaining questions. If not, I'd like to thank you, Professor, for your time and your expertise, and thank you for accommodating your busy schedule and making time for us. And for those that participate, thank you very much for your attention, and thank you for your excellent questions as well. I wish everyone a wonderful evening, and just would like to thank you one last time. So have a great evening, everyone.
Bye-bye. Thank you.